I'll introduce myself and look to my team to introduce themselves individually. I'm Tony Stevens. I'm the Chief Executive of the Northern Trust. Been in post for approximately 6 weeks.
I'm Greg Furness. I'm Interim Medical Director for the Northern Trust. I've been in post since the start of February of this year.
Olive.
I'm Olive MacLeod, Director of Nursing, and I've been in my post for 3 years.
And my name's Margaret O'Hagan, and I'm a nurse by background of some 27 years, and I've been in my post for 1 year as an interim and nearly 1 year in substantive, so coming up to 2 years.
Okay. Tony, if you'd like to make your short statement, go ahead.
Okay, thank you. I'm going to read my statement. It'll keep me disciplined. Thank you for the opportunity to give evidence to this inquiry. We do recognise its importance and its value. I and my team are acutely aware of the importance of emergency healthcare, and possibly more importantly are aware of the public's concern about the accessibility, timeliness and quality of this care. The Northern Trust serves a large population of approximately 465,000 people who come from a very wide geographical area. Approximately 115,000 people visit or use our emergency departments each year, and many more access other health services on an urgent basis. Each one of these people comes with individual concerns and needs, often accompanied by their family and friends who also require support. In providing services to these people, we are conscious of a wider responsibility to improve the overall health of our population, and in particular to reduce health inequalities and address in particular the issue of accessibility. It is our clear duty to ensure also that staff are supported and equipped to deliver the service they provide in a sustainable and safe way. We run 2 acute hospitals with emergency departments, and we also have 2 minor injury units on separate sites. We also provide direct access to hospital services via general practitioners and our community care teams. I have been in post, as I say, for approximately 6 weeks. My appointment marked a new stage in a process of turnaround that the Trust have been engaged in with the Department of Health and Social Services over the last couple of years. The Trust has seen real challenges in the delivery of emergency health care. However, through its own efforts and with the support of a turnaround team, it has delivered progressive and sustained improvement in the delivery of timely care. The headlines are that the Causeway Hospital, one of our 2 acute sites, has had no people who have had to wait longer than 12 hours for a bed in over a year. And Antrim Hospital, our other acute site, has seen a very substantial reduction in such waits. We have also opened a new emergency department at Antrim Hospital that provides the space and facilities to meet both patient and staff needs. These facilities make it much easier to provide privacy and dignity to patients and families, and in particular to meet the needs of vulnerable groups, such as children and the elderly. The progress we have made has been achieved through the very real engagement of clinical staff, our doctors, our nurses, associated health professionals and social care staff, and they've contributed to finding new ways of working and breaking down barriers in the health systems. There has been a genuine commitment, not just from our emergency department staff, but from all our clinical teams, to improve the service to those patients who present needing urgent care. We have also recognised the need to engage with patients and the public, and can describe our approach to this during the hearing. Since arriving in the Trust, I have agreed with staff 4 operational priorities. These include emergency care, elective care, good governance, and financial stability. None is mutually exclusive to the others. We have adopted an inclusive approach to dealing with these, which ensures the active participation of staff and the people who use our services. I hope that through the questions you pose and our answers, we will be able to properly describe the challenges we face and the solutions we are finding to deliver progressive improvements in our emergency care service that meet the needs not only for timely services, but services that are safe, and are delivered in a compassionate and caring way. Thank you.
Okay, thank you. Tony, I'm going to kick off, and I'm quite happy for you to delegate questions to whichever members of the panel or whoever wants to answer them. But you alluded to there, and it's clearly been a very public debate around the need for a turnaround process, and I don't intend to go into that in great detail, but I wonder if you'd take us through, first of all, what are the issues that needed tackling in the first place, that needed turning around? To tell us some of the practical things you're doing in order to do that. And then you alluded to some of the outcomes in terms of targets, but to take us through what you have seen as the progressive improvements, and what are the areas where you still think you've got work to be done.
Okay.
So I'll kind of just very quick, so it's what the problems were, what you've done to deal with them, what's working and what's not working.
Okay. Well, I'll start, and I might look to some of my more experienced colleagues who've lived this journey more than I have to fill in some of the detail.
Sure.
But my appreciation of the situation is that really back in 2010, 2011, 2012, there was a sense that the Northern Trust at key points was not delivering a performance that either met the public's expectations or indeed public representatives' expectations. And there was within the Trust a very determined effort to improve on that, and a very clear focus, in fairness to the staff who worked in the Trust. They knew the issues and they were working very hard to resolve those. Mm-hmm. However, at a point in time it was felt that the Trust needed a little additional support to hasten some of the improvements that were required, and also, I think, to bring a clarity of purpose and thought to that. At its simplest, the Northern Trust has been the subject of a great many reports. I won't list them all. I think we provided you with details of them. But at their heart, they all said very similar things. At its simplest, and it was one of decluttering, simplifying processes, in particular making sure that the entire system ran as one from front door to back door, that we reduced barriers to the most effective care, that in particular we would break down the barriers that might exist between primary care and secondary care, and then again to deal with the barriers or the hurdles that exist between the emergency department and the other services, both in the hospital and in the community. And all of the reports also had a very clear focus on resolving some issues within what we would call community services. The Northern Trust has 2 acute sites, but it has an awful lot of other sites where we provide care, residential care, if you like. We have beds, and there was a view that we needed to clarify that resource and make maximum use of it. And in particular, in my view, to ensure that as people moved from being an emergency to requiring acute care, and then maybe intermediate care, and then maybe community care, that at each of those points we had created a more seamless journey for people, so that we reduced the number of handoffs, we reduced the length of stay, we reduced the number of people involved, and that we brought particularly the community teams and the rehabilitation teams closer to the front door. Other things that we were required to do were to try and improve the situation in respect of alternatives to the emergency department, so providing direct access for general practitioners or indeed our own community care teams. So, for example, having a medical admission unit or having the ability to admit directly to a specialty ward. The other things so were key at a point in time were to start to address some of the very real issues about how particularly our medical teams work. So starting to address 7-day working, starting to reduce the potential for silo working. We have very good and very excellent medical teams and specialty teams like respiratory medicine, cardiology, care of the elderly, but to actually bring them a little closer to if you like, to the agenda of the emergency department, and as I say, and maybe reduce some of the barriers that might have existed. So those, in my view, those were the key issues. I suppose the other issue was to improve the communication that the Trust had with the public and their representatives, articulate a message. And I still believe one of the things we've yet to do is to articulate an absolutely clear vision for the future of the Northern Trust. And that becomes there's a further piece of work to do beyond that, which I think is a conversation with the public, those 465,000 people who use our services, who require our services, a conversation about what they want. Because one of the challenges we face is that although we have this very significant resources, some of them are locked up, and we have to have a conversation that allows people to articulate what it is that are the priorities and how we might remodel our service to meet the challenges of the future. And so that becomes, I think, an essential extension of where we've already been. I don't know whether I've answered the question adequately or either.
Could I add, I'm the Director of Nursing and I've been in the organisation for 3 years, and we accommodated our patients in the emergency department in a very small area. The hospital was designed and built 20 years ago to accommodate perhaps 30,000 admissions, and this year we will see possibly 78,000. So 2-3 years ago we were seeing upon 70,000 patients through our emergency department. So for our nursing staff and our medical staff and catering and support services who are trying to cater for those very large numbers of patients, it became very challenging. It became challenging for us as an organisation to recruit and retain nurses and to keep them motivated, because for them their primary focus is caring for their patients and looking after those patients like they would look after their own loved ones. But that became very demoralising for them, because we were often very congested with many patients waiting to be admitted into the wards with no beds available. We are very fortunate. We have new accommodation, and that has helped us to address particularly the privacy and dignity issues that I had concerns about. The old emergency department had curtained areas. It did not have solid walls. When patients were waiting, they were waiting on trolleys in the centre of the department. It became very congested, it became very noisy, it became difficult for nurses to provide intimate care, I have to say the nurses did a sterling job, but it was a very difficult time for them, particularly through the winter periods. We're in a very nice new facility now. We have been fortunate that our commissioner has invested in nursing and more nursing numbers, because our footprint has increased by 300%. We have proper facilities, proper bathrooms, catering facilities for our patients now. But we are still negotiating with our commissioners to make sure we have enough nurses, because we have a very large area now to look after our patients. So we're spreading, in essence, the same number over a very large area.
Yeah, go on, Margaret.
I was just going to pick up on a few of the process issues, because a new department, the assumption was that the new department would have been the end of all our troubles, and it is absolutely not the case. If you carry on doing what you do, you get the same outcomes. And our journey that Tony talked about really commenced around January 2013. That was before turnaround arrived. We were in this period of assessment for turnaround. We had a colleague from England came over to support that assessment. And indeed, it did coincide with quite a number of senior appointments as well, myself being one, assistant director level new appointments. So there was a really ripeness to do something different. And any journey has to start with the first step, and recognising you have to do something different really was it for me. I just knew that I had to do something completely different here, otherwise we would be where we would always been. So it's important to recognise that, and that started the journey. And using all the opportunities that come your way, spotting the opportunities, for example, a new ward and a new emergency department, actually gave us an opportunity to remodel how we did things. Tony made reference to different ways of assessing and unpicking what had gone before. To get something new, you need to unpick the old, keep what you need to keep, and discard what isn't fit for purpose for now. And one of the things which I think many emergency departments in Northern Ireland, and indeed probably in UK mainland, was everybody should funnel through the emergency department. And that's actually what was one of the reasons that we ended up so congested. Everything funneled through one front door, and that door then became blocked, and then there was one back door out. So what we did was we used the opportunity of a vacated clinical area, albeit not a very big area, to set up a new process for assessing patients that the GPs could directly bring their patients to. We could have rapid access clinics. We could take patients out of the emergency department that were actually suitable to be seen by specialty doctors and by acute physicians. And that has actually been a really, really good success, because what it has done, it is an opportunity to open up doors. And indeed, as such, when we did that, we, in a way, trailblazed what the RQIA put in as a recommendation: open up your doors. Don't have everybody going through one door, otherwise it starts to slow up. So the doctors needed to work differently, and I think the point that must be made that the clinical staff and indeed the non-clinical staff all had a really renewed energy and wanted to do this. And whilst it was very, very hard work, it was relentless work, we knew we had to do things differently. And the numbers, particularly Causeway's numbers, have been fantastic. What I did was I put in a clinical director into Causeway, so it's led by a doctor. And all the evidence is if you've got services led by clinical teams, then they are better services. So we set about the journey of putting clinical teams in charge, and that's another thing that we did do. But, you know, we will never ever get there, because unscheduled care is like the horizon. You're never going to meet the horizon, because there'll always be another horizon. So one of the things that I've done is I've accepted this journey will go on forever. We always want to improve. We will always get to where we want to go, but there'll be a new horizon for us to move to. So that's helped me deal with the relentlessness of it, and the sustainability of it is that's your job to do it all the time.
Can I bring you to the kind of third part of the question, which was what are the things that have worked? And you were talking about this being a progressive. And what are the things where you still have clearly work to do?
Yes, Greg, maybe we'll talk about one issue.
Just to pick up on the ones that Dr. Stevens mentioned in his the specialty take. I mean, if you come in unscheduled care, you know, there could be quite a number of conditions that you're suffering from. It was quickly recognised, I think, at the point that Margaret was talking about in terms of how do we do our unscheduled care, that it was so much better if you can get the expert in that particular field to be looking after you, rather than having you as a generalist cared for over that first few days. So one of the things which has been a success has been that we've initiated specialty takes, so that each day and on a daily basis right through the weekend as well, there will be a number of specialty teams who will take the patients out from the general take, and by doing so, we feel, and certainly the figures would certainly bear it out, that the quality of care and that the things as crude as a mortality rate will be less if you can get the right team treating that patient early. So that's something which we felt was a success, and of course, as a byproduct of that, I suppose, is the earlier you get somebody onto the right course of treatment, maybe the earlier that you'll actually be able to discharge them from the hospital, and hence things such as length of stay have also come down. So in that respect, we feel that has been a success.
I think it would be picking up on that point, just to give it. I mean, one of the things that I've seen since I arrived, in terms of the performance of the team before I had made any contribution, was that they've been very effective in measuring outcomes to provide assurance. So particularly on the Antrim site, but also on the Causeway site, we've seen a very definite and clear reduction in length of stay, performing very credibly against national benchmarks. And that's just one quality measure I know, but at the time that they're reducing length of stay, they have not seen their readmission rate creep up. So that's one. The other thing is very robust review of other outcome measures, in particular mortality, and again benchmarking that nationally and demonstrating very credible performance in terms of that high-level measure of the quality of the service. And the other, if you like, juxtaposition to what Greg's talked about in terms of specialty teams, that our community hospitals or our local hospitals like Robinson Hospital, Dalriada, they have introduced a new medical model with general practitioners providing the care, and we have seen a reduction in our length of stay in those hospitals from over 30 days to pretty close to what we believe is the benchmark of around 21, 22 days. And that's a very credible piece of work for several reasons. One, it reflects that those beds are now being used for the proper purpose and they're actively rehabilitating people back into their home. That actually we've addressed an important issue about engaging with primary care and extending the role of primary care, meeting them in the middle. And also it's increased our resource, because by reducing length of stay by a third, that is a resource that we now have available to us to try and reduce the impact of the increasing workload on our acute sites. And one of the real remaining challenges for us is that as the workload on the acute sites goes up, the space to, as Oliver's very eloquently said, the space available to us and the resource available to us in those acute sites to deliver care can become compromised. So unlocking resource elsewhere in the system becomes absolutely essential to us. So that's a very tangible and real example of the really good work that has gone on over the last couple of years.
Can I give two others?
I'm conscious of time here, so I'm sorry to... Just in terms of then the areas that you feel that you still have real challenges and have major work to do, very briefly, what are the key areas that you think are still the major challenges facing the trust in turning around and completing this journey?
We still have a piece of work to do in developing our medical leadership model. That work is being progressed, and that's a piece of work that I've taken on with Greg to see through, to produce a management model for the Northern Trust that puts clinicians, but particularly doctors, in more responsible positions. And that piece of work is ongoing now, and that remains a challenge. And the Northern Trust has also, I think, a challenge to demonstrate reputationally that it is an open and learning culture. I have seen no evidence to suggest that it isn't, but we have a further piece of work to do to demonstrate and assure the public and those bodies that hold us to account that we are truly learning and are open to learning. So that remains a challenge. The other challenge, and it will be an ongoing challenge, is to unlock resource, because the Antrim, in particular the Antrim site, is probably not big enough. Turnaround would say isn't big enough for the demand. Oliver very eloquently said just how many, the growth in people attending the emergency department. Well, the bed stock available to us is not growing at the same rate. Our commissioner has been very clear, I think clear with you, that the resources exist within trusts to deal with emergency care. And while I wouldn't necessarily argue with that, we nevertheless have to go through a journey which is to unlock resources from elsewhere to be able to focus them in all the areas we need to, particularly if we're going to truly address the demand for emergency care.
Thank you. I've got one other question that I'll pass you to Marion. This is really, so you mentioned about the open and learning culture, and I think I heard earlier the importance of kind of staff involvement in these processes. One of the things that struck the panel to date in terms of the evidence that we've taken has been on the issue of treatment of staff and issue of bullying and whether there is a bullying culture or a problem of bullying. And on the one hand, we've heard from, for example, trade union side and Unison, from the Royal College of Nursing, from the BMA, that is a problem. Not a problem confined to a particular hospital, although obviously the RQIA had flagged it up as an issue in the Belfast Trust. On the other hand, when talking to the trusts, it's been that that's not a problem. And one of the things that struck us is that we're not in a position to, other than there is clearly something disjointed between the evidence of those, if you like, on the shop floor and those involved in management. But one of the things that's clear, if you want an open and learning culture and an involvement, then that's incompatible if there are issues of bullying and staff feeling inhibited. So I suppose two questions for me. One is, what's your sense of whether that's an issue in the Northern Trust? And if it's not an issue, then have you any explanation for why there's such a disconnect between what we're hearing, if you like, from a kind of management view of trusts and what we're hearing from those who represent staff on shop floor, so to speak?
Can I answer? I'll answer for nursing and allied health professionals and support service staff, because they're my area of responsibility, but specifically nursing. As I said, I joined the organisation 3 years ago. It was very apparent to me that I needed to get a baseline of where everybody was at. So I conducted, with my nursing team, a very comprehensive engagement survey 2 years ago. We surveyed and had a return of over 70% of all our nurses, our health visitors and our midwives. This was a validated tool we used, conducted by the Nurse Advisory Board, which is an international body, that, and based on the feedback from, and it asked very probing, robust questions. It was quite enlightening for me, and it actually formed the basis of our nursing strategy. Out of it, we produced 5 themes, and one very important one was our people. We have 5 pledges. In essence, we pledge to our patients and our people and the quality of services we deliver. But I, as the Director of Nursing, responsible for all those allied health professions and nurses and midwives, have several fora that I run to make sure that nurses and midwives and allied health professionals can meet me. So, ward sisters, I have a shared governance arrangement, which means that on our very senior nursing, we have 2 ward sisters that represent the community nurses and the ward sisters. So their voice is heard at the highest level in the organisation. I think we have built a lot of trust with those levels of nurses. We also have a lead nurse forum, and we have a specialist nurse forum. So the nurses have their voice. I have communication councils, which is in essence an open door. People can come and talk to me. I have a very healthy relationship with my director colleagues. So where we have concerns, we will deal with them. We will support our staff, because we acknowledge that our nurses and midwives and our allied health professions and all others are the most important resource we have. And they are the people who look after our patients 24 hours a day, 7 days a week. If they don't feel engaged, if they don't feel connected, if they don't feel valued, they're not going to, our patients are going to potentially suffer. And we're very mindful of that. So out of that drives our strategy, and each of our directorates has a small working plan, and they report to me on every 2 months, and they have picked out of the strategy what it is that they are going to do that will deliver in their area of responsibility, and if they have any challenges. So I'm disappointed that our trade union colleagues would feel that way. I visit all the wards very frequently. I visit the community teams very frequently. I hope I have an open style of engagement with them, and I think they are, first and foremost, I point out they are professionals. They have a code of conduct, and it is their responsibility to raise concerns with me. I can't fix everything, but if there is an area of concern, they must raise it, and we will address it together.
Can I make I suppose, a philosophical comment and a practical comment?
Sure.
I've already indicated I've been a chief executive in Northern Trust for a relatively short time, and in fact, I'm chief executive for a very short period of time. But I have 8 years' experience as a medical director in another large trust in Northern Ireland. Most of the evidence, most of those opportunities where staff have been surveyed, and for example, all trainee doctors participate through the GMC in an anonymised trainee survey every year. And in the previous organisation I worked for, which had over 700 trainees, the number of incidents of the trainees who could do this perfectly anonymously indicated that there was undermining or bullying going on was actually very, very few. And that doesn't say that there aren't individual exchanges between staff that are unhealthy or lack respect. I suppose as a doctor I would also make a philosophical comment that there's an assumption that the bullying is always done by management and that actually the clinical staff are somehow virtuous in all this. Professional hierarchies exist in healthcare systems, and management is not the only professional hierarchy, so there is sometimes a robust exchange. My own sense of this is that the word bullying is getting a little bit of mileage at the moment, and credence is an easy allegation to make and a very difficult one to refute. But we do take this issue very, very seriously. So my philosophical point and the basis upon which I have managed my entire career, and at every induction I have run for consultants and junior doctors, I make it very clear to them that, firstly, very few doctors will ever lose their job for being open and honest. The only time that I ever know a doctor ever knowingly get into trouble is if they've actually broken the law in some way, and that's beyond my power to deal with. They have a significant health problem, and that is between them and their regulator then as well. Or if they completely fail to have any insight into their ability and fail to learn themselves. I have never come across a situation where a doctor has been seriously bullied or intimidated in such a way as to prevent them from being open or to raise a concern. I genuinely have never seen that. And it's completely counter-strategic, because the message I give all doctors is if you're in trouble or if you feel something's gone wrong, the quickest way to deal with that is to be completely open and honest. Be completely open and honest with the people that may have been harmed by your actions, and be completely open and honest with your clinical supervisor, your consultant, your management team. The only thing that ever gets a doctor, and I think a nurse as well, into trouble is actually trying to cover up or not be open. Because very few people, if people have made a mistake, are honest about it, or if people have a real concern about the quality of a service and are honest and open about it, that's the best protection against any criticism. And it's so important to us as an organisation, because as an organisation, we are in exactly the same position as any individual. We get into most trouble when there is an accusation that we have not been straightforward with the public, with the public's representatives, with professional bodies. So it is not ever in our interests. In my now fairly lengthy career in senior management, I have never seen a situation ever where it is in any individual's best interest or the organisation's best interest not to be anything other than completely open. Now, you may have to explain a situation, and you may have to, sometimes that you may have to manage the situation so that you don't cause anxiety or panic. And I've been accused of not being open, for example, when if you have to call patients back because there's been a concern about the quality and care, and you're calling patients back and you try and manage the timing of that, and the media sometimes get frustrated that you didn't come straight out and tell them, whereas what we're doing is trying to properly manage something that might cause a great deal of anxiety. So, my philosophical point here, and I'm sorry this is a very long answer, is that there is nothing in it for management or the senior management or the executive of any organisation to do anything other than encourage openness, because that drives quality improvement. And it pains me when I hear people say that we have a bullying culture, we're not open, because I genuinely don't see the evidence of it. I take a view that, and it may not be entirely an appropriate view, but I take a view that actually whistleblowing is a failure of the system. If you have to enact a whistleblowing policy, if somebody feels they need the protection of a whistleblowing policy, your system's failed, because you should have already known about the problem, because people should have already come forward. And again, I have never seen a truly altruistic whistleblower. And not all whistleblowers are, of course, truly altruistic, but if they're truly altruistic in their actions, ever suffer any misadventure as a consequence of being open. So I'm sorry that's a very long answer. I can't explain the difference between staff side and management, other than I believe, and I don't know a single manager, senior manager, who doesn't share my philosophy.
Okay. Thank you. I'm going to pass you now to Marion.
Good afternoon. I have just two questions, and really around meeting patients' needs. I'm wondering, to begin with, could you outline how you assess how well your emergency care departments are operating to identify and meet the needs of patients with particular needs, such as children, those with dementia or mental health problems? And have you any plans in place to improve the way your emergency departments respond to those patients?
I think I'll look to Margaret and Olive here. We'll maybe talk you through some of the real improvements that have come in paediatrics with the opening of our new emergency department. But I'll let you just take people through that.
Yeah. I'll touch base probably firstly on the process element of children and indeed other very high-risk groups. We have mentioned, well, we have the two emergency departments, one in Causeway, one in Antrim. Antrim was blessed with a purpose-built emergency department that there was extensive input by clinical staff in its design. And one of the things that we're particularly pleased about is how it was designed for children. We are the only emergency department in Northern Ireland to have a dedicated children's area. And again, I talked earlier about you need a new process, other you'll end up with the same thing, only in a different building. And we set about planning that in a very different way. We used feedback from families, parents, and indeed some older children and their families' experience of their children going through our system before. We looked at how, and indeed acknowledged our challenges around retaining nursing staff with specific skills and competence in relation to children, and worked with our children's director, Olive, myself, and our colleague in children's to develop an innovative way of how we could retain nurses. Indeed, we have children's nurses rotate through that emergency department, and that's had really, really good unintended positive consequences for the hospital in general. The area is then staffed, dedicated with medical staff. It is small, as in, for children, small equipment, small seats, colourful, very playful. We have the paediatricians in reach into that department as well if they are required, and we have a dedicated resource area within our resuscitation section for children. So that's, from a process point of view, that's been a really, really good benefit. Children in Causeway don't have the benefit of having that dedicated area. Nevertheless, great effort is made to bring the service to children. We have a teddy bear club, which once a month schools come in and we teach them not to be frightened about being unwell, being in a hospital, and that's been a huge hit in Causeway, and it's now commencing in Antrim. The paediatric team in Causeway also in reach into the department. So they do the best they can with their geography that they've got, and indeed we get some excellent correspondence feedback from parents, both of the clinical team and the care people get, and they seldom focus on the where they've had it. The older people, older patients, and indeed patients with mental health or with Alzheimer's, we have the butterfly scheme, which has been implemented throughout all our hospitals, and the emergency department is no different. Our nurses are trained, our medical staff are trained to be able to identify and support patients with Alzheimer's and their families. We acknowledge that those type of patients, and indeed patients with mental health illness and children, are time sensitive, and we try and speed them through the department because that can add to their anxiety, and indeed it can add to the anxiety of others in that department. So very, very much focused on that, rather than just processing patients just as patients. People are treated as individuals. So there, maybe some of my colleagues want to.
And in relation to the butterfly scheme, I'm sure you're aware of it, but all our porters, because they move our patients around, all our cleaners, because they come and clean the rooms, all our catering staff, all had the butterfly scheme training, so it increases their sensitivity in relation to patients with dementia. We also have a dementia strategy, a nursing dementia strategy, and in each of our departments, and particularly our emergency department, we have dementia champions. So nurses, healthcare assistants who are particularly interested in dementia or have had a family member, and they are the person who will bring new learning back in, support new staff in relation to dealing, because often with patients with dementia, it's the fear of how to communicate with that person. All our signage is dementia friendly. We're mindful that our jugs have colours, so that we are all those things. And I think our new department in Antrim has been very supportive, because we have rooms to look after patients, because emergency departments can be very noisy, so we can get people in. In relation to people with learning disability, we have a very specific piece of work we've done in relation to learning disability, and we're working with our families and our clients and patients who have learning disability, and we've designed a passport that they will take in with us to hospital if they're particularly coming to the emergency department with an emergency, so that we know what they like to be called, their fears. If we know in advance, we can arrange for them to come in and get them into a cubicle quietly, or if it's for x-ray. So we've worked with our x-ray staff, because it's very frightening for anybody to have to go for a CT. So we're very mindful of, but we have used our patients and their families to help us design some of the areas for improvement in relation to emergency department.
Okay, thank you very much. My final question relates to several years ago there was a report done on Antrim Hospital which talked about the internal movement of patients and the risks that pose to their health. And I'm wondering, to what extent has that problem been addressed in terms of not only internal movement within the hospital, but within your hospitals?
Yes, I'll take that. As Dr. Furness said, we have designed a new model, a specialty take model. So we try to get patients from the emergency department into their specialty wards as quickly as possible, so we reduce the number of moves. In the past, yes, we were moving because we had a different model, and we were moving, but we set ourselves a target 2 years ago to reduce the incidence of transfers after 10 o'clock by 50%, and we have achieved that. The night sister tracks all patients that are moved, and we try to identify early in the day if we need to make capacity for beds, that we make those moves happen earlier in the day, so that we're not disturbing people, because we were very mindful. One of the feedbacks we got from patients in our survey was about noise at night. So we did a very specific piece of work in relation to noise at that, and part of the reduction of noise at night is not moving in as many patients and moving them out of their beds and moving them to different wards. So I track that personally on a monthly basis, the number of people that are moved, and we have seen it dramatic. We are still a very, very busy hospital, and we see many of our admissions come into the evening who require beds, but we try and identify the beds earlier in the day so we can place those patients and get them settled for the night, because their sleep is as important as everything else.
Can I add to that also? We have introduced a new process throughout the day, which again realises what all of us just said, in that we have pretty much brought into our working day, which is right up to about 7 in the evening, the bed availability. So we know now, in the past we would have seen a lot of patients still waiting to be discharged, still waiting to leave the hospital quite late into the evening, and then the beds only then become available. And so therefore what we've done is we've mapped in quite early in the day processes to be able to find out when and how, and indeed we introduced a discharge lounge to try and allow patients to leave their bed, because Antrim is such that there's no space beside the beds, there's no day rooms in terms of its fabric. So introducing the discharge lounge brings the patients to another very comfortable area where they then can continue until they can leave the hospital safely, meanwhile freeing up the bed quite a lot earlier. So we've moved a lot of that into daytime hours, because as Olive says, we've recognised that one of the reasons patients are delayed is because the beds have been so slow, and to free up the right bed for that patient might have required somebody to be moved about. So it's been really quite successful, particularly over this past few months, where we get far less discharges happening later in the evening. They're happening more so during the earlier part of the day and into around tea time or shortly thereafter.
Thank you very much.
Paul?
Thank you very much for your help this afternoon. We really appreciate it. We're already over time, but I have permission from the chair to take a little more time. But I'll try and keep my questions crisp, and perhaps you could try and keep your answers crisp. I know that's not always easy for either you or I. Firstly, a question about morbidity and mortality review process. Does the Northern Trust, have a morbidity and mortality review process?
Can I look to Greg to answer that question?
Yes, we do. It's not perfect. Instead, it's one which is under review currently. As it stands, the specialists are divided up into specialty families, each of which will form a local governance group. Each of those groups will meet on approximately a monthly basis. They will then review morbidity or mortality which has occurred in the period that they're looking at. The bit that we're trying to, I suppose, smarten up will be to make sure that there is a systematic approach to it rather than just looking at leaving them to be totally sort of, well, we'll look at this one, not this one. So there is activity across the piece. It is improving, as I said, in terms of trying to get the identification of cases on a more systematic method. We're also trying and are making it more multidisciplinary than it has been in the past. So basically, yes, it is done at a local governance group level. They also, as we mentioned earlier, look at the mortality figures which come in from an independent source, CHKS. So we have the review of those figures, and again, this is something which we are in the process of improving, should we say, to make sure that each of the local governance groups is aware of their own specific part of that bigger picture.
Greg, I'm sorry if I'm being a bit slow, but what do you mean by local governance group?
Okay, it will be a group of clinicians led by one of them, so there will be a group leader. They will, as I say, organise themselves into a monthly meeting where they look at both morbidity or mortality or themes which may, they feel required to be looked at. They would also look at some of the information coming in from outside of the organisation to look at learning letters and guidelines, whatever, as they come into the organisation. So I say the structure is there and the activity happens. It could be better joined up. I feel that this is something which we are endeavouring to do, and to make sure also that the learning has occurred. It's all very good to say, we identify a problem, but it's then important to make sure that the whole thing is made and that the learning is actually embedded.
Paul, could I add just one other point to this? Since arriving, I've instituted an independent review of governance in the Trust to include clinical governance and include morbidity and mortality. We've also reviewed at a high level all the mortality data, and importantly, at a workshop of our board of directors, we're bringing a detailed presentation on morbidity and mortality for a lengthy discussion with our non-executive directors. In order that, for two purposes. The first, to truly ensure that they have the skills and knowledge to be able to interrogate mortality data, so it's not left to the docs to interpret it for themselves, and also then for them to actually have in detail both high and more granular information on exactly what's going on. So it's an area of very active development for us at the moment.
I should also say that we are taking our part in the regional efforts led by the Chief Medical Officer, to try and introduce a sort of a more systematic way of ensuring that all the mortality that occurs actually does get reviewed, so that it's sort of a mixture of IT and process to try and make that happen. So that's being rolled out over the next few months, I would.
Thank you. And Tony, would serious adverse incident process, would that be part of this review that you've recently asked to take place?
Yes, the review we're carrying out is a complete review of integrated governance. The philosophy that I would wish to bring to Northern Trust, and indeed the philosophy they already had, was one of true integrated governance. So we're reviewing all aspects, including health and safety for staff and all the other things that will be equally important. But yes, the SAI process will. We are to some extent constrained by the regional guidelines and policy and procedures on serious adverse incidents, but that itself is being reviewed, as you know, by Sir Liam Donaldson. And we're hopeful that it may become a more practical tool for us going forward.
And I noticed, you'll correct me if I'm wrong, but I think you said that one of your 4 priorities on taking up office was governance. And in your remarks you talked about a conversation with the public, how important that was. So could I just pursue this a little bit, because I think the issue of health governance is absolutely crucial. And of course, we're particularly interested in emergency health care, but that has to be located in a larger system and a larger system of governance. So I'd really welcome your views. They might be provisional and preliminary, but your views about this. And I said I'd keep my questions crisp, but if you could just allow me to indulge myself just briefly. One vision of a healthcare system is that it's a public institution serving the community and belonging to the community. That's one vision. There are other visions, but that's one. But of course, the healthcare system is extremely complex. And it depends upon the specialist professional expertise that you and your colleagues bring. So if that vision is right of a healthcare system serving the community and belonging to the community, if that vision is right, then it becomes really important, and I think difficult, it becomes really important to ensure the public is closely involved in the governance of that system. And I think this is a major challenge for all of us. So how does one maximise public participation in the governance of your trust? How do you do that? And obviously I've asked this question of others, and I understand there are patient users groups, and I understand there's 10,000 voices, and I understand and we've spoken with the Patient Care Council and so forth. So, there are elements of participation, public participation already, and I'm just really interested to know, and my mind is open on this, I'm really interested to know from you and others, whether or not you think the present governance structures for public participation in this healthcare system that belongs to the community, do you think the present governance structures about participation, do you think they're enough? And maybe they are. I really don't know. I'm interested in your view.
I'll give you a view, and if my colleagues want to contribute to this, I'm more than happy. The short answer is no. I don't think that they're enough. I think there's much more that we can do. Because to my mind, ultimately, governance is about assurance and providing and confidence. It's about providing an assurance that you're meeting your objectives, that you're providing a safe service, that you're providing the right service. And it's about giving the public, the people who use your service, confidence in the services they're accessing. So at the end of the day, everything comes down to confidence. So if the public lack confidence at any point in time, then actually you're not doing enough. I have a view that in Northern Ireland, and indeed elsewhere, we have not done enough to strengthen the boards of directors of arm's length bodies like trusts. So if I was to say to you that the first part of public engagement in governance is actually to ensure that the legal entity, the board of directors, is fully discharging its responsibilities, that non-executive directors, who are ultimately appointed as representatives of the public, are fully able to exercise their duty to provide an assurance and to challenge the executive. I think that we have to do more there. I've made this comment elsewhere, that I think we need to actually look at how we can strengthen, if we are to have trusts in Northern Ireland, which are arm's length bodies with a legal entity and a board of directors, and we must do more to strengthen the hand of the board of directors, to provide challenge and to provide assurance for the public and for the minister. That's the first thing I would say. So I've already indicated that I want to do more with my board of directors, my non-executive directors, to ensure that they are both equipped and have access to the data they need to interrogate. The other thing then is to engage the public much more, both in terms of helping to co-design our services and be involved from the very beginning in developing the services so that they actually understand them, that they are engaged in developing the strategic direction for the organisation so that they can have confidence in that, and that they're also, when things go wrong, that they are fully informed, and individual families and patients are fully informed and engaged. And one of the initiatives, again, that occurred before I arrived that has been very powerful is at the board of directors, we're inviting at each board of directors meeting somebody, a user of our services who's possibly had a less than good experience, to come and describe their experience to us. So, at a very practical level, engaging our board, engaging the public in the business of our organisation, but also through our various engagement with user groups and carers groups and articulating the issues and trying to create I might use the word coalition. For us as a senior management team and for the entire management of the trust to succeed, we have to form a coalition with the people we serve. We have to have, in my view, we cannot succeed if we do not have a shared vision. So the best example for me at the moment would be the Causeway Hospital. There is a little bit of concern about the future of the Causeway Hospital. I think the problem, and one of the problems we're having is we're having a problem recruiting doctors to work there because they're not absolutely certain that they'll see out a career in the Causeway. And one of our absolute, and I think that's unfortunate, and I think it's now incorrect, but one of the key things we have to do is create a coalition between the public, their representatives, the professionals, the clinicians, and the management and the commissioners to describe a vision for what a service can look like. And that has to also incorporate those aspects of governance so that they understand why we make decisions sometimes.
Tony, I'm really interested in this, and I'm very interested in how you characterise the non-executive directors as sort of representatives of the public. I think that's how you put it. And I think this is extremely important and tricky and interesting. Can you please remind me, just very briefly, how many directors are there on your board?
It's good to double check this. I think it's six. Six. I think most boards in trust boards have 6 non-executive directors.
Six non-execs, and then other members.
The trust board will be made up of legal directors who are the medical director, the director of nursing, the director of social work, the finance director, and the chief executive.
Right.
And then there will be other directors who sit on the board who would what would be called non-legal directors or non-executive. Well, they're not executive directors.
Right.
Those legal or executive directors counterbalance exactly the executive directors. But the board will, for example, Margaret as the director of acute services always also sits there.
Okay, so it sounds like there might be about 15 of you, something like that,
yes.
Very roughly, and 6 of those are non-executive directors. And again, excuse my ignorance, remind me who appoints them, the non-executive directors?
There's a public appointments process,
yes.
And through which people are identified. People apply for jobs, they're nominated, they go through a recruitment process, and then, as I understand it, they seek a ministerial approval for that.
So in the end, the sort of buck stops with the minister appointing these people. And how often does your board meet?
It meets at the moment every month, and more often if need be.
Right. And they're public meetings?
Yes. At the moment, I actually want to introduce a system of public meetings and workshops where we can get down into detail as an educational process for our non-executive directors. At the moment in the Northern Trust, we have a monthly meeting, and it's public.
Right.
We have a reserved section if there are any issues,
of course,
for example,
yes.
of patient confidentiality that will prevent us doing it in public.
Yes. And I'm going to have to stop shortly, but the non-executive directors, I'm interested in their role. Do they report back to the public in any way? So there they are sitting on the board, that is your trust board, and so there'll be these discussions, and they can vote, I think. Can they can vote?
Well,
Yes.
approve. Yes, it seldom comes down to having a vote, but most strategic and policy issues have to be approved by the board of directors, and
including them.
And most reports on quality. Yeah, well, particularly them.
Yes.
And indeed.
So do any of them sort of, let's say they come from one particular community, professional community or whatever, do they, having sat on a board meeting, would they then go back and sit with their community and say, we had this meeting last week. I just mean very informally, just go back to their community and say, this is what's happened, this is a problem, don't know what to do about this, what do you think of this? Are they a sort of link to different constituencies within the Northern Trust? Do you see what I'm getting at?
No, I do, and I don't think they're quite there. I think the reality is they're mostly appointed because of a professional expertise, for example, in finance or social care. But certainly in Belfast, for example, we had a politician who very clearly linked back into. We had a Sinn Féin politician on our board, and still do, and he was very, very clear in his responsibilities to reflect the views of his constituency.
But that sounds a bit exceptional.
It probably is.
Yeah.
I
wasn't thinking of political parties, actually. I was thinking more of, those working in disability, for instance, going back to their communities, or those working with ethnic minorities going back to their community. Do you see what I mean?
Yes.
And I have the impression that doesn't quite happen.
No.
Okay.
We're not quite that far.
Okay.
I think they have a really important role in governance and assurance, and therefore you are looking for a group of people with certain skills.
Yeah.
But most of them come from a fairly wide church, particularly with a social science background or social care background, financial background, business background, and they take their responsibilities very seriously to challenge and to represent a public view. Now, we don't necessarily have the systems in place which allow them to truly represent the public, and I'm not sure that's actually their role, but that would be something that would be an interesting further extension.
Thanks very much for your help.
I think that concludes. Tony, I'd just like to say thank you to both you and your colleagues for your evidence. An invitation that we've made to everybody who has given evidence. We would more than welcome if you want to provide a further written submission to either augment what you've said today, or if you think there are areas that you think we should know about in terms of the Northern Trust within the inquiry and the emergency department, we would be delighted to take any additional material that you have. And it just remains to say thank you for coming along today and giving up time, which I know is at a premium in terms of all of you, and good luck with the further work in terms of turnaround of the Northern Trust. Thank you.
Thank you. Thank you very much.